Thank you very much for this introduction. I will talk about acute kidney injury after postpartum hemorrhage. And let me introduce this presentation with some definition. First, postpartum hemorrhage occurs in 5% of deliveries, and it is still the leading cause of maternal mortality in developed countries. It is defined as a cumulative blood loss greater than 1 liter within 1 day, and is still a major public health issue. Pregnancy-related acute kidney injury is an acute kidney injury that occurs during pregnancy or in postpartum period. The incidence rate of overall patients during pregnancy is about 2%, but the leading cause of pregnancy-related AKI is postpartum hemorrhage. It increases maternal and perinatal mortality and can lead to chronic kidney disease in a young population, indeed, for example, 2.4% of patients with acute kidney injury during pregnancy will progress to end-stage renal disease. So our primary outcome was to identify independent risk factor for pregnancy-related AKI after PPH, and to develop a predictive risk score to predict acute kidney injury after PPH. Our study is an ancillary study of HealthMom study. HealthMom study is a prospective, multi-center French study conducted between 2014 and 2018, which included 342 patients with severe PPH. In more detail, to be included, patients must have present a postpartum hemorrhage and had to receive sulprostone, which is an agonist of prostaglandin, which an heterotonic action. And after inclusion, we have to consider two important time points. First, at inclusion, clinical and demographic data were collected, and patient first blood sample were taken. And this is at this moment that we have identified risk factor of developing acute kidney injury during hospital stay. And the second time point is occurs during hospital stay. Patients were carried a second blood sample, which included creatinine concentration, to know whether or not they had acute kidney injury. So to summarize, the idea is to predict the occurrence of acute kidney injury during hospital stay based on predictive factor available at inclusion. About the definition is a composite definition based on the KDIGO definition and a serum creatinine concentration threshold of 1 milligram by deciliter. We have excluded chronic kidney disease, patients with chronic kidney disease, and patients with acute kidney injury before delivery. And we include 297 patients, and we have 43 patients with pregnancy-related acute kidney injury, about 10% of overall patients. And we have identified 5 independent risk factors of acute kidney injury after PPH. Proton time under 50%, preeclampsia, high-sensitive troponin T greater than 30 nanogram by liter, NT-proBNP greater than 400 nanogram by liter, and fibrinogen under 2.5 gram by liter. And based on this regression model, we have developed the MOMACI score. MOMACI score included each of the 5 independent risk factors previously described, and each variable were attributed a number of points according to its weight in the prediction of acute kidney injury during hospital stay after PPH. And for example, when we have 0 point, we have a probability of acute kidney injury during hospital stay under 3%. When we have more than 5 points, we have a probability of acute kidney injury more than 80%. The predictive performance of this model is good, with an C index about 85, and the sensitivity and specificity are good too. Another interesting result of our study is that acute kidney injury during hospital stay is associated with a poor outcome during hospital stay. For example, we have more transfusion, more frozen flesh plasma and red blood cells transfusion, more coagulation abnormalities, lower platelet count, lower fibrinogen levels, PT levels. We have more cardiovascular abnormalities, which included an elevation in troponin level, BNP level, or abnormal EKG. And we have more advanced interventional procedures, which included hysterectomy and radioembolization. And we have more hemodynamic failure. So pregnancy-related AKI is associated with adverse outcomes during hospital stay. And the MOMACI score could predict acute kidney injury from the early phase of the management of PPH, but also poor outcome during hospital stay. So to conclude, we have developed a good predictive performance risk score, an easy-to-use risk score, and it allows the early identification of patients with a more severe prognosis and at high risk of developing chronic kidney disease. And it underlies the interest of biomarkers in the management of PPH through the troponin T and NT-proBNP. So we need a validation cohort, but we are actually working on it. Thank you for your attention.
Any question? Moucho. Can you have the microphone to our... Ici, la juste première rang. C'est le monsieur brésilien, là. C'est le Paulisto.
Thank you. I thought it a very interesting study. And you mentioned that this risk score can lead to less mortality. And I'd like you to tell me, when is the exact time to use them?
Yes. Yeah, thank you for your question. It's a very good question. First, the first question is practical use of this score, and it allows us a more closely care of our patients at high risk of developing AKI, and we can know it at the early phase of the management. And it is interesting. We can perform a closely hemodynamic monitoring. We can avoid nephrotoxic drug. And the second point is that we can identify patients at high risk of developing chronic kidney disease, and we can, at the early phase, think to make an appointment to a nephrological follow-up after the hospitalization, because the mortality of PPH in the developed country is very low, but the mortality is a crucial issue. And about the second question, can you just ask the time? Yes. So the time, it's at the early phase. The risk factor is at the early phase of the management of PPH after administration of sulprostone at the initial phase of the hemorrhage, and the median average of the second blood sample is 2 days.
Yeah, thank you. And to echo what you are saying, in fact, we just got a big government grant to give glyphosine as a trial, blinded, half of the patients with and half of the patient without, in patients coming out in critically ill condition. Because as we just discussed earlier, glyphosine is really a miracle today, improving vessels, improving the heart, and more importantly, is one of the few drugs that nephrologists are going to use, because it's one of the few drugs that is restoring and recovering kidney dysfunction, then our study will start, named DAPA ICU, will start the next year with François Després, but it will give you the answer. Thank you very much for all this.